Good evening, everybody. Today, we begin a classroom series. We have with us Dr. SWATHI, who's a neurologist in Kauvery Hospitals, Chennai. Today's topic is on pharmacotherapy in myasthenia gravis. So, we'll be talking a little bit about the pathophysiology and the tests, the diagnostic features for myasthenia gravis, and then we'll go into the pharmacotherapy. So, over to you, Dr. SWATHI.
Yeah, thank you, Dr. Sindhu. So, hi everyone. Today we are here to discuss about the pharmacotherapy in myasthenia gravis, and today's topic will more deal with acute presentation of myasthenia gravis. That's a myasthenic crisis. So, we'll be discussing more on myasthenic crisis and its management, and in subsequent sessions we may discuss with for the normal therapy that the treatment of myasthenia gravis in an OP setting and in different types of myasthenia, how we treat our patients like ocular myasthenia, myasthenia treatment elderly population, myasthenia treatment in pregnancy, myasthenia in children, so and congenital myasthenia. So all those treatment part we'll have in further sessions, but today's session is mostly concentrating on the myasthenic crisis. It's acute management. So first we should know what is this myasthenic crisis and this impending myasthenic crisis. So a patient of myasthenic gravis who present with respiratory failure which needs mechanical ventilation or a non-invasive ventilation in order to avoid intubation, except when these measures are employed during routine post-op management or a delayed extubation for more than 24 hours in an already intubated patient myasthenia gravis is termed as myasthenic crisis. And what is impending myasthenic crisis? A rapid clinical deterioration where the physician feels that the patient could land in a crisis in a short term, like in days, 2 weeks. So that is impending myasthenic crisis. So both this myasthenic crisis and impending myasthenic crisis, both are indications for admitting a patient in an ICU setup. Next slide, please. So as I said, both are required to be admitted in ICU. And most of the patients will develop crisis, like 20% of the patients will develop crisis in the first year of our diagnosis, myasthenia gravis. And one more thing that we should be very careful is, patient will present to us just with respiratory failure, and we will be wondering for a diagnosis. And that would be the first presentation of myasthenia gravis. So myasthenia gravis can present to us as a first episode of myasthenic crisis also. So 20% patients will present with crisis as a first episode of myasthenia gravis. So in case we get any patient with a respiratory failure in an ICU, always think about myasthenia gravis. So it's a dictum. It's a dictum like our professors used to tell us that if a patient comes to you with respiratory failure in ICU setup, there are so many causes of ICU weakness, like the Guillain-Barré syndrome, the ALS, the botulism, the Clostridium infections. Yes, but one differential definitely should be myasthenia gravis. And there's one other entity called as cholinergic crisis, which we'll be discussing later also. This cholinergic crisis will also present exactly like a myasthenic crisis, and even those patients will require an ICU admission. So in detail about cholinergic crisis, we have in further slides. Next slide, please. So how does this myasthenic crisis occur? So either the patient is a known case of myasthenia gravis who comes with a crisis, or the first episode itself is a myasthenic crisis. So a gravis patient coming with crisis, so these are the precipitating factors, so like an infection or any surgery, an electrolyte imbalance, a thymoma recurrence, a pregnancy, or even childbirth, an inadequate myasthenic treatment or an inappropriate treatment with drugs that exacerbate myasthenia. So all these can be the precipitating factors for myasthenic crisis. So why we should know these things is because when we treat a myasthenic crisis patient, we should also give importance to all these factors so that we can correct the underlying cause which leads to the crisis. So hence all these infections, surgery, the electrolyte imbalance, the thymoma, the pregnancy, all are precipitating events that could bring about a myasthenic crisis. Next slide, please. And this slide tells us a patient who comes to us with respiratory failure. We don't know that he's a myasthenia gravis. The first presentation as respiratory failure. Then what should we do? We can go with bedside testings, neurophysiological testing, and antibody testing. But however, when a patient comes to us in crisis, it's very difficult for us to go for a neurophysiological testing like a repetitive nerve stimulation or a single fiber EMG. It's very difficult for us to perform it. Where in repetitive nerve stimulation, we can see more than 10% decrement in the CMAP amplitudes. And in antibody testing, we can go for acetylcholine receptor antibodies, the MuSK antibodies, the LRP4 antibodies. However, those reports are going to take time for us to make a diagnosis when the patient comes to us with myasthenic crisis. So we'll not be dealing with those investigations in detail today. The main focus will be on the bedside tests that are available to us. So the two important bedside tests that will be available to us will be, one will be the hydrophonium test and the second will be the ice pack test. So the ice pack test, the very simple bedside maneuver where you have to just take ice and place it for 2 minutes over the eyelid of the patient. So what we have to do is you have to put a protective clothing over the eyelid of the patient so that we don't injure the eyelids of the patient because of the cold exposure. And then you keep the ice for over 2 minutes. And then after removing it, you can observe for the improvement in the ptosis component of the patient. So that is how the cold ice test will help us, and ice pack test will help us in diagnosing myasthenic crisis patient at bedside. So why there is an improvement when their temperatures are low? So one possible mechanism is that the acetylcholine esterase activity, which degrades the acetylcholine, its activity is reduced when the temperatures are low. So the acetylcholine esterase is the enzyme which degrades acetylcholine. The acetylcholine esterase activity is decreased actually when the temperatures are low. And the second postulate is that acetylcholine receptors, the release of the acetylcholine receptors quanta is actually more when the temperature is decreased. So hence the ice pack test, there is an improvement in the symptoms of the patient. So that will help us to detect that patient has a myasthenia as a cause of weakness in the ICU. And the second test that we can go is the hydrophonium test or the neostigmine test, which is quite obsolete now. We don't go for the test unless all the investigations are negative. We go for the test. So hydrophonium test is done by 2 mg. You initially inject 2 mg followed by 8 mg in the second dose after 5 minutes. And then you observe for the improvement in the patient. So you have to set a point for your improvement, either the ptosis or the extended arm position, and then you wait for the improvement in that. So that is the hydrophonium test. And whenever we do this neostigmine test or the hydrophonium test, we should be sure that we always have atropine with us in hand to manage the complications that could arise because of the hydrophonium test and neostigmine test. And that's the main reason we don't do those tests now. And similarly, neostigmine test also, we do the same thing. We actually use 0.04 mg per kg and we give IM injections. So that is how it is done. Maximum you can go up to 1 mg of body weight. You have to give IM injections. We don't go IV injections because the risk for cardiac arrhythmias, and similarly monitor with the endpoints. So these are the bedside tests that will help us in diagnosis of myasthenic crisis patient who comes to us in ICU. So this is the first presentation of myasthenia gravis as a crisis that will require this investigation. For a known case of myasthenia gravis who comes to us in crisis, we have to look out for the other precipitating factors. Next slide, please. So this table is just for us to know the different types of antibodies that would be seen in different types of myasthenia gravis. I'm not going to give a much detail on it because this topic will be discussing again in other sessions. So like we should know more of ocular and generalized myasthenia gravis. The acetylcholine receptor antibodies are the main antibodies that we see, and in generalized myasthenia gravis, almost 80% we can detect acetylcholine receptor antibodies. When ocular, acetylcholine receptor antibodies are seen only in 50% of the cases. And one important thing that we should remember is thymoma patients. They have the other antibodies like the titin and the rhinodin. So that is one different point that we should do. And we have some cases which we call as double seronegative myasthenia gravis. Means they don't have acetylcholine receptors also, and they also test negative for MuSK also. So in that 5 to 10% of patients will be positive for LRP4. And this LRP4 is nothing but they help in clustering of the acetylcholine receptors in the postsynaptic area. So clustering of all the receptors occurs by means of this LRP4 and all other, we have a lot of rapsin, DOX7, all these help in clustering of acetylcholine receptors. So when they are deficient also, we will have this myasthenia gravis. So this table is just for the completion sake. Next slide, please. So this is a nutshell. We get a myasthenic crisis patient to the ICU first. Sometimes 20% of the cases we have without a previous diagnosis. Then we confirm the diagnosis by the important bedside test, the ISPAC test, and other cases we have where the myasthenia gravis is previously diagnosed on the right side of the table chart. In that cases, we are going to stop the anticholinesterase and continue immunosuppression. So we will be discussing detail in about every step in the further slides. And in the ICU, we'll take care of the general critical care. We'll avoid and treat the systemic complications. We'll evaluate the bulbar and the respiratory functions and provide them ventilatory support if needed. We'll search for the precipitating factors, and then we'll go for a specific rapid therapy in the form of immunotherapy, plasmapheresis, and corticosteroids. So this is a flow chart, and this is how the further slides will be. Like, we'll be discussing on every step of how we are going to manage a myasthenic crisis patient. Next slide, please. So these are the red flag signs for the impending myasthenic crisis. So we had a definition called as impending myasthenic crisis, which according to the physician, he feels that the patient is going to land up in a proper myasthenic crisis over a few days' time. So if these symptoms are present, then we have to suspect an impending myasthenic crisis, like a febrile infection in the past 2 weeks, where patient had taken antibiotic, an inverse aspiration, which is nothing but aspiration of the food and the liquids to the mouth or the nose, and insufficient swallowing or insufficient coughing, or patient is not able to clear his secretions, aphonic dysarthria, a dropped head or a dropped chin, like when the patient is having his food, his chin is dropped, he's not able to close the mouth, or a new facial weakness, or a vital capacity of less than 20 ml per kg body weight. So all these are red flag signs for the impending myasthenic crisis. Next slide, please. So as we already discussed, whatever myasthenic crisis or impending crisis, we have to admit them in a neurocritical care, and we search for the inciting drugs and other precipitating agents. And one important thing that I would have highlighted at this point is the inciting drugs have to be immediately stopped. The most common drugs are the the antibiotics, the aminoglycosides, fluoroquinolones, and the beta blockers. Most of our cardiac patients will be on beta blockers. So all these three drugs are the most common offenders that we see, and the US FDA has special black box warning for fluoroquinolones and telithromycin as inciting drugs for a crisis. And based upon our assessment, we can decide whether patients require a non-invasive ventilation who are able to manage their secretions. But if there's prominent bulbar signs where they are not able to manage their secretions, we'll go for an elective intubation. And we also have further other criteria, the forced vital capacity and the inspiratory pressure, with which we will decide whether the patient requires an intubation or not. Next slide, please. And next, we'll be actually dealing with this is in a nutshell, the table which tells you all the drugs. And for easy remembrance, we should remember like A for antibiotics, and you have B for beta blockers, and then you will have B for Botox also, and C for corticosteroids, and D, you can remember D penicillamine, and also your non-depolarizing agents like the curare family, the atracurium, rocurarium. So all those families. So A, B, C, and D. And the other drugs that we should remember is the procainamide, the quinines, and important is magnesium, and the statins. And of late, now we have started getting this immune checkpoint inhibitor. They have been now widely used from the oncology setup. The immune checkpoint inhibitors that has come as a new entity, the pembrolizumab, the nivolumab, the avelumab, all these drugs now cause what we call as immune-mediated myasthenic gravis, and that entity is different from the normal myasthenic gravis. Next slide, please. So we also discussed about cholinergic crisis that will also require admission in our ICU setup. So paradoxical weakening because of the anticholinesterase treatment that we give is called as cholinergic crisis. It's very rarely seen, and it occurs with dose limitation of pyridostigmine to less than 120 mg every 3 hours. So a dose of almost 900 is required for us to even start seeing the cholinergic crisis features coming up, like excess salivation, lacrimation, GI intolerance, all that. But it is said that it is very, very rare, and the dose has to exceed the range. And they also say even if we have all features of cholinergic crisis, since it is so very rare, they consider it as myasthenic crisis and they want us to treat it also like myasthenic crisis. Next slide, please. Now, when the clinical assessment, which we all know, I think you will be well aware of the clinical assessment. Next slide, where we have to look for the breathing pattern, the speech and the bulbar function, and the spirometry. That's a clinical assessment we do with our patients. I think you will be very well versed with that, as you see all emergencies where patient is feeling breathless while talking or swallowing and having a rapid shallow breathing, tachycardia, and whenever there's a neck flexion weakness, myasthenia gravis presents more of with neck flexion weakness, and that actually mirrors our diaphragm weakness because of the same nerve innervation. So neck flexion weakness is a very important sign, and we should however know that there's one entity called myasthenia gravis where neck extensors are more weak when compared to neck flexion. So that is one point which we need to know, because the musk myasthenia treatment is different. They worsen with our normal treatment, and we have to go for immunomodulation like rituximab. So neck extensors are weak in case of musk myasthenia. Otherwise, myasthenia gravis presents with neck flexion weakness, and that actually mirrors our diaphragmatic weakness. And we should then look for the axillary muscle weakness like the paradoxic abdominal movement. And when that starts occurring, it means the vital capacity has fallen down by 10%. That is almost 500 ml. And then the speech and the bulbar function may be assessed for the nasal speech of the patient, where there's a broken speech, patient has a weak cough, patient is not able to clear the secretions, there's a choking sensation, there's fluid regurgitation, and a diminished palatal reflex. Next slide. And the next assessment that we do here is spirometry, where if we have a portable spirometry, then we can rule. So sorry for the technical glitch. Okay, so 10-30-40 rule that actually tells us for triggering an ICU admission. So I think you will be better versed versus like the forced vital capacity of less than 20 ml per kg, and peak inspiratory mouth pressure, or the NIF, the negative inspiratory pressure of less than 30 centimeters of water, and the peak expiratory pressure of less than 40 centimeters of water. So the 20-30-40 rule that we use for detecting whether a patient requires intubation, and based on these values we can also plan for a weaning and an extubation. And so the peak expiratory pressure will indicate that it is insufficient cough to clear the secretions. And the next slide. So we'll be just going through fast through these slides because I think you'll be knowing this better. And they actually say all these values have to be measured at baseline, and then you have to follow it as a trend. Like typically, every 6 hours. Actually, most of the literature I went through says every 4 hours in a patient. That is based on our clinical assessment. They are asking us to assess every patient for every 4 hours at least, and they say that the trend of number, that is the one that is more important rather than the individual measurement. And based on that we can decide whether a BiPAP is needed. So like a BiPAP may be indicated earlier for FEC less than 20 ml per kg, or an NIF which is worse than 30 centimeter of water. And if the patient is able to clear his secretions, if they are able to manage their secretions, then we go for a BiPAP. Next slide, please. So in places when we cannot have a portable spirometer, so one assessment at bedside that will help us to assess for the vital capacity will be the single breath count. You must be knowing about this, where we ask a patient to count numbers in a single breath, and each number will indicate 100 ml of vital capacity. And so now 10 numbers shows that the vital capacity is 1 liter, and anything less than 10 we are going to intubate our patient. Next slide. And again, these are just a few points like please do not rely on the pulse oximeter to show a desaturation, or an ABG to show a hypercapnia or a hypoxemia. They are not a good indicator for respiratory stent, especially in myasthenia gravis, because they all develop very late. When there's a life-threatening respiratory failure, only then they will start showing findings. So please do not wait for the ABG to show changes for like hypercapnia, hypoxemia, or a pulse oximeter to show a desaturation, because weak respiratory muscles will suddenly fatigue up, and then there will be precipitous respiratory collapse. So always go for these bedside measurements of forced vital capacity, the single breath count. The next slide. And this is also the same thing. These are the values of vital capacity, negative airway pressure, positive airway pressure, uh, which will help us in design for intubation, weaning, as well as extubation. Next slide. So for the impending crisis also, the same thing we have to do. You monitor the swallowing assessment, you look for the oxygen saturation, all the above factors that we discussed so far, the clinical assessment, you have to go do that. And they also ask us to go for a QMG analysis and ABGs. Next slide. So this is, as you all know, what are the absolute indications for intubation. So bulbar is for dysfunction with confirmed aspirations, hypercapnia, profound hypoxia, lobar atelectasis, contraindications for your BiPAP, and the rest are all general specific like respiratory arrest, cardiac, impaired consciousness, shock, life-threatening arrhythmia, severe blood gas that we discussed, profound hypercapnia and hypoxia. So all these are the absolute indications for intubation. Next slide, please. And so it is the same where you go for NIV, BiPAP, or you go for elective based on the previous features that we are going to assess. Just one point, I think that also you would be well versed with. Administer low dose of non-depolarizing blocking agents like 0.5 mg per kg of rocuronium instead of 1 mg. And most patients require actually median time of intubation that we see in myasthenia gravis that they have put up in literature is almost 2 weeks. And extubation failure is also seen well. Almost 40% of extubation failures are seen just because myasthenia gravis is a fluctuating disease. There is extubation failures are also seen. The next slide. So, and these are all general precautions that we do where decision when we do not know whether the above criteria is very difficult to be met for intubation, and if you are in doubt, then just intubate the patient. Use of bronchodilators and very aggressive pulmonary toileting is essential for treatment of the patient. Do an aggressive chest physiotherapy. Ensure patient has adequate nutritional support of 25 to 30 kilocalories per kg, and withdrawal of all the precipitating agents, and a low molecular weight heparin for prophylaxis for DVT. So these are general measures that we do as a part of the treatment. The next slide. So then the proper management where we go for pharmacological treatment and the and the cholinesterase inhibitors. So usually in an impending crisis patients, we continue the cholinesterase inhibitors, but once the patient is intubated, we stop the cholinesterase inhibitors because there will be too much of profound secretions. Hence, we stop the cholinesterase inhibitors as the patient is also intubated and we are already providing him the respiratory measures. So we stop those drugs. However, remember, as I already discussed, this MuSK antibodies, they have very poor response, intolerant to acetylcholinesterase inhibitors. Not only they have poor response, but they also cause paradoxical worsening also. So MuSK antibodies, acetylcholinesterase, the cholinesterase inhibitors will be leading to paradoxical worsening. Next slide, please. So next slide, we'll be discussing about these study drug dosages. So like how much of pyridostigmine should we use? So 60 mg 6 times a day, maximum of 540 mg per day can be used. And then we are dealing with the equivalents. The next points are all equivalent. Like oral pyridostigmine is to IV pyridostigmine. So what is the equivalent ratio? Is 30:1. So in case we are going to give a 360 mg of oral pyridostigmine, that equals to 12 mg of IV pyridostigmine. So these are the doses of conversion on oral pyridostigmine versus the IV pyridostigmine. Similarly, they say an alternative regimen of giving pyridostigmine is bolus of 1 to 3 mg followed by 0.5 to 1 mg per hour. So this is an alternative way of giving pyridostigmine IV. And the next point is neostigmine. Suppose we want to convert the pyridostigmine to neostigmine IV equivalent, then its pyridostigmine oral is to neostigmine parenteral is 80:1 ratio. So 360 mg of this pyridostigmine is to 80:1 ratio. You want to give neostigmine, that is 4.5 mg per day of IV neostigmine. So these are the basically drug dosages that I have provided in this slide. And how you give neostigmine, they ask us to starting dose of 6 to 12 mg per day, and then you can adjust it. And sometimes even bolus also you can give. So this is basically the equivalence. And this, yes ma'am, next slide. Next slide, please, ma'am. And the next table also tells us the same thing, like neostigmine in oral form, and we have IM form and the IV form. So those dosages, and pyridostigmine oral and IM and IV. So how much does it contain? So that that is the table about. Next slide, please. So what is the immunotherapy that we are going to give? So we have now given the acetylcholinesterase symptomatic treatment we have done, and now we are going to do a rapid treatment for the myasthenic crisis. So that is done by two things, either a immunoglobulin, IVIG, or a plasma exchange, both are standard care, and they have found that both are equally effective, but not combining them. Combining the therapies is no benefit, so we can go for either of them. But there have been a lot of studies that they have conducted, and they found that though both are equally effective, the plasma exchange has got a good fast, it's more effective, it's a fast effective way of treatment, and it also reduces the ICU stay. So plasma exchange, this is an expert consensus, it's not a guideline, it's an expert consensus that plex is going to be showing a fast effective therapy. So we'll be now looking in detail about IVIG and this plasma exchange. Next slide, please. Excuse me. So yes, sorry. Plasma exchange is nothing but directly removes the acetylcholine receptors from the body. So beneficial clinical effect takes almost 3 to 4 weeks for us to occur. So the typical course of treatment is usually 5 exchanges over 7 to 14 days, and it's 3 to 5 liters of plasma each. Usually 3 liters of plasma is what we do, but we have in specific how much has to be removed ideally. And they ask us to do it on alternate days rather than doing it daily. So why every other day we have to go? Because it's probably more effective in reducing the antibody levels because of the time it takes for the extravascular immunoglobulin to regain equilibrium after each exchange. So for the extravascular immunoglobulin to regain equilibrium after every exchange, it takes almost 24 to 48 hours. That's why they ask us to do this plasma exchange every alternate days. It can be done daily in some, but usually what we practice is alternate day regimen. Next slide, please. So for most of the conditions, the standard practice is 1 to 1.5 plasma volume exchanges per procedure has to be done. And single plasma volume exchange, average size adult approximates usually 3 liters of replacement fluid. So we have this formula which is used to estimate the plasma volume in most of the adults. So how we estimate the plasma volume liters is 0.07 into weight in kg into 1 minus hematocrit. So that will tell us the estimated plasma volume in liters. Next slide, please. And then coming to the replacement fluid. So we over 7 to 14 days gap, alternate days, we have to do at least 5 cycles. And every time we do it, we give replacement fluids. So we have 3 replacement fluids. One is the albumin 5% or a normal saline. And the third is combination of albumin and normal saline. These are the replacement fluids which are available. However, it is specified like for myasthenia, going for 5% of albumin for myasthenia as replacement fluid. And the complications that you come through is because it induced hypocalcemia and metabolic alkalosis. So after every plex plasma exchange that we do, we follow up the patient with the calcium levels in order to prevent look for hypocalcemia. And the other complications that we have with plasma exchange is removal of medications, and it also depletes the patient of coagulation factor and even hypotension, hypokalemia, and hypocalcemia. So like already patient is in shock, and then we're going to remove lot of plasma, like the patient may go on for hypotension. And when we deplete the patient of coagulation factor, then the patient tends to have a more of bleeding tendencies. So that part also we have to be very careful when we do a plasma exchange. Next slide. So next we will discuss about the IVIG. So it's not IVIG is nothing but pooled immunoglobulins from thousands of donors, and the dose that we use is 2 grams per kg, usually divided over 2 to 5 days. So they have done trials with 1 gram per kg and 2 gram per kg, and they have found that there is no difference in either of the doses, and it is as equally effective. So that means we can give the patient of 1 gram per kg, considering the cost effect of IVIG, we can go for 1 gram. But what we usually do in our practice here is 2 gram per kg of IVIG is given divided over 2 to 5 days. So the only thing we have to be more careful is what we have to choose in IVIG and Plex will go with the patient's scenario, the cost effects, the adverse effects that the patient is likely to get. So based on that, we will decide plasma exchange IVIG rather than sticking on to that. The Plex's plasma exchange is going to have a fast effective. So we'll go for plasma exchange. No, IVIG is very easy to give. So we'll go for IVIG. We don't do it that way. We clinically assess which will be more appropriate for the patient. And in heart failure patients and renal disease patients, IVIG you have to give in a very slow dose and even in infusion rates. Next slide, please. So most of these preparations are more than 95% of polyvalent IgG. However, we should also know that these IVIG preparations which we come, we're going to discuss about the IVIG preparation in this particular side, where they also have different stabilizers like the sucrose, glucose, maltose. Why this is very essential for us is because certain stabilizers will have certain complications which we have to be careful when we give it to the patients, and at times you can avoid those preparations specifically. So, like this maltose and glucose, we should be careful with diabetic patients. Diabetic should be very careful when you give this glucose containing products, because certain types of glucometers will not be discriminating between maltose or glucose. So, hence, that is one thing we should know about these preparations. How do these preparations come? The next slide, please. The one stabilizer with sucrose, products that contain sucrose, actually now they are not available in the United States. However, they can, what happens is they were seen to cause increased risk of osmotic renal injury. Like AKI is being observed as a complication of IVIG, and especially with sucrose. So you have a patient who has a renal failure, who's already a known case of chronic kidney disease, you ensure we don't give IVIG which has sucrose as its content. And sorbitol, this should be avoided in patients who have hereditary fructose intolerance. And patients who have trouble tolerating increased intravascular volume, you have to be also see that we also have IVIG preparations which are low in sodium and albumin. So hence we should be knowing the constituents of every IVIG that we get. So if you think patient is a heart failure patient, we have IVIG preparations with low sodium and albumin content also. Next slide, please. So before you give IVIG, do we need pre-medication? So as such, there is no guidelines or the dictum that you have to give any pre-medication. There's nothing like that. But if it varies with physician to physician, if you feel in clinical assessment, you feel do not want to have any untoward reactions towards the IVIG, then yeah, you can go for a pre-medication. It's not the rule, but you can if you want. So what is the pre-medication that you give? Either you give an acetaminophen in the 10 to 15 mg per kg body weight, or you go for Brufen 10 mg per kg body weight. So it accounts for 400 mg in adult. Apart from that, some clinicians also prefer giving H1 antihistamines, frequently given before the beginning of infusion. Next slide, please. So we can use diphenhydramine. I have mentioned the dose 1 mg per kg, and or 25 to 50 mg oral, IV or IM in adults that can be given. And sometimes when there are severe reactions or a patient is already known to have, but this is like myasthenia crisis patient, we're going to give. Sometimes they may, or we can also go for IV glucocorticoids instead of oral. So methylprednisolone or hydrocortisone, and either of one can be used. If you already know that the patient already had some untoward reactions previously, then you can go for that, where methylprednisolone dose will be 0.5 to 1 mg per kg, and hydrocortisone will be 2 mg per kg or 100 mg IV in adults. So there is no dictum that we have to use. It only varies with physician to physician whether you want to give this or not. But we do not follow, like in our we never used to give this unless we know the patient may have a reaction, we're expecting something, already known case of allergy, something like that, then maybe you can go for this. Otherwise, even we use acetaminophen and we use diphenhydramine and hydrocort. These are the commonly used. If at all we use methylprednisolone, we don't use much for the pre-medication. Next slide, please. So do you want to prehydrate your patient? Usually we don't prehydrate our patient. You should be well hydrated prior to the infusion, especially this is very important patients where they have a CKD, there's already a renal insufficiency, or there's a diabetic patient, patient has got a paraproteinemia. In those patients, you hydrate them because of the complication of thromboembolism in patients. Hyperviscosity and thromboembolism occurs with IVIG. Because of that, hydration should be given before IVIG preparations, especially containing sucrose containing IVIG preparations. We do prehydrate the patient. Next slide. So with what should we prehydrate our patient? We can prehydrate either with an oral hydration is enough, or at times if we need, you can go for even normal saline prehydration, like 10 to 20 ml per kg. So that is the they have given us this is the type of hydration that we can go for. And how do you give the infusion rate? That is important. So IVIG has to be given at a very slow rate. Usually, like we run over 6 hours to 8 hours. That's how we run IVIG. But we have the infusion rate as 0.1 ml per kg per minute. That provides zero point 0.5 or 1 mg per kg of IVIG. So zero point 0.5 is 5% IVIG and 1 mg per kg is 10% IVIG. So you start with 0.01 ml per kg per minute, and then you want, we can increase the infusion rate at 30-minute intervals, and you increase the rate to 0.02 ml per kg per minute, then to 0.04 ml per kg per minute, to a maximum rate of 0.08 ml per kg per minute. So the infusion rate of 0.08 ml per kg per minute will be corresponding to 4 mg per kg of IVIG per minute for a 5% solution of IVIG. So this is the infusion rate that we should follow. And usually they say you administer the IVIG in a separate infusion line from that of the other medications. But if you are using the same primary line, then you flush the line with normal saline or a 5% dextrose. The last point here for the IVIG will be the vaccination. Like when you give an IVIG, what about the vaccination schedule? So they have seen, like for COVID patients, this IVIG has got nothing to do with giving COVID vaccination. So you can give before or after of the IVIG infusions. It has not decreased the efficacy of the COVID vaccines. However, when you use live vaccines, they have found that they do interfere quite with live vaccinations. So when we are planning to give a live vaccination in a patient who's receiving IVIG, it's just said that it varies with each vaccine. Like approximately 3 to 11 months is the time interval that they want to give between the IVIG infusion and the vaccination for live vaccines. So it's 3 to 12 months. It varies. Certain vaccines like MMR, they say it's 6 months or 9 months. So it varies anywhere from 3 months to 11 months of IVIG infusion, the interval between the IVIG infusion and the vaccine schedule. So next slide. And yeah, this is the last slide. This is the same slide where we discussed about plasma exchange and IVIG versus. So there are several studies that suggest that plasma exchange has a more rapid effect and leading to fewer intubations and earlier extubation also. So this was a consensus statement. The Myasthenia Gravis Foundation of America suggests that although two treatments are likely equally effective based on the available evidence and should be chosen based only on clinical characteristics, plasma exchange may be more effective and has faster effect is the consensus expert opinion. So, but when in our practice where we see a lot of myasthenic crisis patients, what we prefer actually is a plasma exchange. That is what we prefer because of its very rapid effect. Like by the time you do 2 sessions of plasma exchange, patient starts responding so well when compared to completing the entire IVIG course. You complete the entire IVIG course and you still don't find any improvement. While like not no improvement, this slowly the improvements start coming. While in a plasma exchange patient, like even after 1 to 2 sessions, we start seeing improvement. So that is how rapid effect we see. So we actually choose plasma exchange in our setup more, except when the patient is in hypotension. Whenever we have the contraindications, which we already discussed, we go for an IVIG. So better advantage of IVIG is it's just a drug which you can just give just intravenously, where you need not have to get the complications of the procedures that you do by doing a plasma exchange. You have to put a dual central line, do double human central line. So all that can be avoided by giving an IVIG. However, we have side effects of IVIG, which also we should keep in mind. We'll be looking through the adverse effects in the next following slide. Next slide, please. So like IVIG has anaphylaxis and anaphylaxis-like reactions, and immediate reactions can be like pain, headache, migraine, and volume overload, and even trally. And so we do see a lot of patients who come to who tell us that they have severe headache after IVIG infusions. Like that occurs. We have an entity called as aseptic meningitis is quite a common complication of IVIG. So to avoid that headache, what we have to do is it's just the infusion rate. So go for a slow infusion rate. If your patient is a cardiac patient or a renal failure patient, you go for a very slow infusion rate. Not only that, the infusion rate is slowed down. So like if we are going to divide the 2 grams per kg body weight of IVIG over 5 days, we divide it over 5 days. But in cardiac patients with low EF, in such patients, we actually divide it for even 7 days or 8 days. So we stretch around. So instead of giving four bottles of, like we get 5% like 5 grams each vial, and then we give 20. For example, we give 20 each day. Then the 4 vials we just divide and give, like one in a day we just give 2. We start with 2 and every day we give 2, and then later on we step up to 3, seeing how the patient is tolerating the volume overload. So like that, slow in infusion rate and also distributing it over extended time period, that is what we do in clinical practice. uh, and the similarly, a slow infusion rate will also help for a headache, or to prevent headache. So, and the delayed reactions that we may get is the thromboembolic events like stroke, a myocardial infarction, a DVT, a pulmonary embolism. All that are that are the main side effects of IVIG. So we should always keep these side effects in mind and then choose which we need for our patient, whether an IVIG or a plasma exchange. And the AKI, there is acute kidney injury, hyponatremia, and the delayed reactions also have the hematological complications like hemolysis, neutropenia. And the late reactions, the dermatological reactions, and patient will be at a risk for infections. Next slide. So the next therapy that we come, we have done a rapid immunotherapy of IVIG and plasma exchange. But for any myasthenia gravis patient in crisis, we should always give them steroids. All patients of myasthenia gravis have to be given steroids in the dose of 0.75 mg per kg to 1 mg per kg ideal body weight. That is the most commonly used if there is any other while receiving other immunomodulatory therapy also. So only one catch is that we know that steroids paradoxically worsen a myasthenic weakness. It worsens. So usually in an OP setting, we always go for lower dose of steroids. We only start the patient with 20 mg of steroids, and gradually we increase it up. And then as a patient is good enough, then we start tapering it and we bring it to alternate day of steroid therapy. That's a minimal therapy that we give in OP basis. But in a myasthenic crisis patient, since our patient is already intubated here, so we can go ahead with a higher dose. The normal dose of prednisone here, that is 1 mg per kg, can be start, so that paradoxical worsening is actually here compensated because you already intubated our patients. But in case you're going to do it for a non-intubated patient where there is an impending crisis, then be very sure we have to monitor our patients with all those clinical assessment that we discussed for those patients, and be very vigilant about it. And so when do we see this transient worsening of weakness? When you start corticosteroids. So transient worsening of weakness occurs with steroids usually within 5 to 10 days after initiation of glucocorticoids, and it lasts approximately for 5 to 6 days. And the effect of corticosteroids starts occurring by 2 weeks. A minimum of 2 to 3 weeks, we start seeing the beneficial effects of corticosteroids. Next slide, please. And there are also other chronic immunomodulatory treatments that can be used. So like we have some patients where there may be contraindications for steroids, and we will not be able to start them on steroids along with the plasma exchange or an IVIG. Then what is the next thing that we can do? You have other chronic immunomodulatory therapies, the azathioprine, the mycophenolate mofetil, the MMF, the cyclosporin, tacrolimus, and even the rituximab that can be used when glucocorticoids are contraindicated. Now we have got these two drugs which have come, efgartigimod alpha and ravulizumab. Even these two new drugs have been used for crisis patients, can be used when glucocorticoids are contraindicated. So I've not discussed much on the dosage, the side effects of all this, because we'll have this in the other sessions which we'll have. Next slide, please. So, and the chronic immunotherapy that we already discussed, so azathioprine, all that can be added so that they increase the remission time and decrease the relapses, and all the other second line agents. So basically, a steroid sparing strategy can be used where we use the other chronic immunotherapies for these patients. Next slide. So the idea basically is that we are going for a steroid sparing agent, but the thing is, once the IVIG effect and the plasma exchange effect starts coming down, like IVIG's effects can be seen only up to 3 weeks, because that's the half life of IVIG. After that, what? After that, what happens is rebound of the antibodies again starts happening. So when there's a rebound effect, to control the rebound effect, that is the reason why we start corticosteroids along with IVIG and plex therapy. That is the reason why we start along with an IVIG and plasma exchange. Steroids are started, and this immunotherapy started along with those therapies, because once the effect wanes off, there will be a rebound increase in the antibodies. And we can also use rituximab, that is for refractory patients, like refractory myasthenia gravis patients. we have two drugs, cyclophosphamide and rituximab can be used. And also for musk patients, the musk antibody myasthenia gravis patients, they improve only with rituximab. So for them, we have immunotherapy of rituximab. Next slide, please. So, what's the prognosis? So we are coming to the fair end of the presentation. Like, yes, the mortality is actually quite high, 5 to 20%, but it has actually come down very significantly since the ICU and the technologies of ICU. And 20% of the patients require mechanical ventilation will be requiring ventilator support even at the time of discharge. So, what are the factors that will tell us that these patients will be requiring a prolonged mechanical ventilation? Will be the age, pneumonia, high disease burden, late onset myasthenia gravis, and higher pre-intubation carbon dioxide that was most associated with disability and death in other studies. Next slide, please. And I already we discussed some few points like extubation success will be very difficult to predict because myasthenia gravis is a fluctuating disease and failure can be as high as 40%. And like this cough strength and the maximum expiratory pressure like of greater than 40 will help us predict that it has a good outcome because that maximum expiratory pressure is the one which tells us the clearing capacity, the cough clearance capacity. So that and all will help us. And of those who actually survive hospitalization, up to 80% is going to have a very good functional outcome at 12 months. And mostly the median time that required for intubation is almost 2 weeks. So most of the points are that we already discussed previously. On the next slide. So what are the future? Even this point I've already discussed. So there we now have new classes of drugs, the immunomodulated drugs, the immune checkpoint inhibitors, which are coming up in other fields. So it's just seen that they are bringing about they are also triggered medications which can lead to immune mediated myasthenia gravis. So this immune related myasthenia gravis is actually carrying a high mortality rate and it is more difficult to treat when compared to the classic myasthenia gravis. This is future things and new things which is coming up with myasthenia gravis. So what has to be done is further studies are needed so that we know actually what is the type of myasthenia gravis they bring about and how the treatment protocols, whether they need a change or not, that has to be further evaluated. So next, so last, so this is all in a nutshell that we already discussed. I think we'll like you assess the patient clinically about the bulbar dysfunction, dyspnea, the flaccid tetraparesis, and if you suspect myasthenia gravis, go for your bedside test and confirm your diagnosis, and then you keep continuously monitoring every 4 hours with the QMG, the vital capacity, the expiratory pressures and the inspiratory pressures, and you look for the red flag signs. As required, you intubate the patient or you just monitor the patient and you eliminate all the precipitating factors, the precipitating drugs, the low molecular heparin, the adequate nutrition. Next slide. It's just a flow chart. It's like a protocol kind of. Next slide. And then you initiate our therapy in the form. Yeah, so where you give pyridostigmine and you decide to stop pyridostigmine if the patient is already intubated because then secretions are so profuse to control when a patient is intubated. And you also start the immunomodulated therapy along with the plasma exchange and IVIG because as the effects of IVIG and plasma exchange wanes off, there will be a rebound increase in the antibodies, which we do not want. And because cortisone will at least take 2 weeks to start showing its action and effects, so you start along with those plasma exchange IVIG. You can also use other immunomodulated drugs, which we discussed, and you just stabilize the patient. Still, the patient doesn't improve, then go for rituximab, and finally consider weaning and a long-term therapy based on all the FVC values which we discussed, the MIP and the maximum expiratory pressures. The next slide. The last slide is just again the same summary in short. So I think I've quite repeated long term. These are the references. Thank you.
Thank you, Dr. Swati. So I just had one question to ask you. Like you told that after
Yeah.
the plasma exchange, you said only albumin and normal saline are used as a replacement fluid, but we also used to use FFP as a
FFP.
replacement fluid.
Yes, ma'am.
Yeah.
Yeah, we also FFP. But I don't know for myasthenia, it is specifically said in the literature to go only for 5% albumin specifically. I don't
Okay.
know the reason. I couldn't find out the reason. Maybe I will try to find out and maybe I'll try to give a answer in the next session. But it's specifically mentioned that myasthenia go for 5% albumin as the best. But yeah, in our what we practice is we go for albumin if it's available, but mostly it won't be available. So actually, we give FFP. That is what we do. And because FFP has also got all the coagulation factors, it's more preferred steroid.
And one more question.
Yes.
Um, when the patient is on the ventilator, you said that steroid should be started.
Yeah, yeah. We have to
Yeah,
start,
so
ma'am.
what would be your choices? Is it going to be like methylprednisolone, or is it going to be Dexa, or is it going to be Hydrocort?
Ma'am, usually what we do, we start the patient on oral prednisolone only. We have never started with hydrocort or injection methylpred. We usually start prednisone 1 mg per kg body weight. Because usually myasthenia gravis, we don't use such high dose of steroids. It's one condition where we use only low dose of steroids, like 20 mg per day. And then we gradually escalate if needed. And we introduce an immunomodulator drug by then. A steroid sparing immunomodulator is added. And then we taper and bring it down. That is what we do in OP practice. But in a crisis patient because he's intubated, why we go with a slower dose and start escalating is simple reason because there's a paradoxical worsening of weakness on high dose of corticosteroids. So that is why we start with low and escalate up. But since the crisis patient is already intubated, we start with a higher dose and we usually use steroids, oral tablets of prednisone only we use, ma'am.
Thank you, Dr. Swati. That was quite a exhaustive class. Thank you so
Oh,
much. And I think the subsequent classes will deal with the chronic immunomodulatory therapy of myasthenia gravis.
yeah.
Thank you. Thank you, everyone.
Thank you.